I understand you had your long case today.
Yes.
Any problems to report?
No problems today.
Please proceed.
Thank you. Today I had the pleasure of meeting Richard, a 62-year-old Māori gentleman of Ngāti Kahungunu and Te Rarawa descent, who has recently lost his long-term job as a truck driver due to complications of diabetic retinopathy. This comes on a background of poorly controlled type 2 diabetes, high cardiovascular risk, and functionally limiting back pain from a previous injury. I'll start by discussing a number of elements of his medical background. The first is that of Richard's type 2 diabetes. So this was diagnosed in 2012 on routine screening with his GP. The risk factors he has for this include obesity, his age, and a sedentary lifestyle. Regarding the effect of his diabetes on his daily life, Richard doesn't have any particular symptoms from this, such as polyuria or thirst. Discussing his glycemic control, unfortunately Richard rarely tests his blood sugar levels, and he doesn't actually know where his glucometer is from when he was last given one. We also discussed his HbA1c level, and he actually reports he's never heard of this and doesn't know what his most recent one would be. Discussing the complications of type 2 diabetes for Richard, regarding first the microvascular complications, as mentioned earlier, he has evidence of diabetic retinopathy that he is known to the ophthalmology service for and receives regular Avastin injections. As mentioned, and I'll discuss this in more detail later, this has been progressing over time, and Richard has actually recently lost his job as he lost his his heavy vehicle license due to the effect on his vision. Regarding other microvascular complications, Richard does not believe he has any chronic kidney disease, although he does recall doctors in the past talking about his kidneys being affected by his diabetes. He has never had to see a renal doctor related to this. Lastly, regarding the effects of diabetic neuropathy, Richard does note that he has at times felt like he was walking on cotton wool, but he has never seen a podiatrist regarding his feet. He similarly does not believe he's ever had a diabetic foot ulcer, nor any significant infections related to that. Regarding the macrovascular complications of his diabetes, Richard has neither had a stroke, nor has he never had a myocardial infarction, but I note that, as I will discuss soon, he is at very high risk for both of these. Similarly, Richard is not known to have any peripheral vascular disease, despite the suggestion of some diabetic nephropathy. Regarding how Richard's type 2 diabetes is managed at present, we did briefly discuss his diet, and he doesn't believe he's ever given any particular diet advice around managing his diabetes. Regarding the current medications he takes for this, he is on metformin 1 gram twice per day. He also takes gliclazide 80 milligrams once daily, and has been prescribed dulaglutide 1.5 milligrams subcutaneous weekly, but actually notes that he has not been taking this since it was prescribed, as when he received the pen from the pharmacy, he didn't know what to do with it, so has not been taking that. His diabetes at this stage is managed by his general practitioner. He has not been engaged at any point with a diabetes nurse specialist that he knows of, nor any hospital diabetes services or allied health in relation to this. The next element of Richard's medical background I'd like to discuss is that of his high cardiovascular risk. So, the risk factors he has for this include, as mentioned, his type 2 diabetes with evidence of poor control, as well as hypertension, obesity as previously mentioned, current smoking, and his ethnicity places him increased risk as well. Similarly, this doesn't give Richard too many symptoms, and he probably doesn't put much thought to it, and he's never had angina, and as previously mentioned, has never had a myocardial infarction. He doesn't know what his usual blood pressure would be, but he is on medications to treat hypertension. On measuring this today, it was 148 over 96 millimeters of mercury. We briefly discussed some investigations he may have had in relation to his cardiovascular risk. Richard has never had a coronary angiogram, nor an echocardiogram, or a carotid Doppler ultrasound. As mentioned, he is taking medications to manage some of this risk. He is currently on perindopril 2 milligrams once daily and amlodipine 10 milligrams once daily for blood pressure management. He is on atorvastatin at the dose of 20 milligrams per day, and as previously mentioned, he is on medications to manage his type 2 diabetes as well. Regarding non-pharmacological management of his cardiovascular risk, all he could really tell me was that he knows not to eat bad foods, but we did not discuss in detail what these might include. He also has not had any particular exercise or activity intervention to support him with this. And as mentioned earlier, he lives quite a sedentary lifestyle as a truck driver in his main occupation. Similar to his type 2 diabetes, Richard's cardiovascular risk factors are all managed by his general practitioner. He has never met with any hospital specialists such as cardiology to manage this. The third element of Richard's medical background I'd like to discuss is that of his back pain, which, as mentioned, has quite a significant functional impact on him. So Richard has had lower back pain since an injury in 2021. This was sustained while lifting a heavy box at work. He had significant pain at the time and went home to rest and was off work for a number of days. He reports things gradually improved and he slowly returned to activity, but he did not seek medical attention at the time. He has no background of skeletal or spinal disease separate from this, and he has never had a significant injury like this in the past. Regarding the current symptoms he experiences from this is felt as a lower back aching pain that is localized mainly to the central lower back. It does not radiate particularly to either side, although Richard will experience electric shock sensations down his legs at times. He describes it as a low level of background pain, only something like a 1 or a 2 out of 10 on the pain scale, but he notes that often with activity such as heavy lifting, this will flare quite significantly. He hasn't at any point had any weakness in his legs, nor has he had any bowel or bladder dysfunction related to this. Regarding investigation into the cause of back pain since 2021, Richard has previously had a plain film X-ray performed by his general practitioner, and he was told this showed wear and tear, but was not given any further details. He has at this stage never had an MRI scan in relation to his back pain. In terms of how this back pain has been managed over the last few years, Richard was referred to physiotherapy through ACC at the time, and he reports going to the first session but didn't find it particularly helpful and did not continue to see them. As mentioned, he has also had to take a number of days off work, both at the initial injury and occasionally since, to allow him to rest, as he felt that makes the back better. Regarding the current pharmacological management of Richard's back pain, he currently takes a number of as-required medicines on a fairly, what sounds like quite an erratic basis. This will include paracetamol 1 gram up to 4 times a day, diclofenac sustained release 75 milligrams up to twice a day, and codeine phosphate 30 to 60 milligrams also up to 4 times a day. Richard doesn't take any of these on a particularly regular basis, but just takes them when he feels the pain has become too severe. Of note, Richard's back pain was one of his biggest concerns, as having just lost his job due to his diabetic retinopathy, he is now concerned about the types of work he will be able to do, given the limitation of his back pain affecting things such as heavy lifting. I'd like to finish this section by discussing some other elements of Richard's past medical history that are less significant or active at present. This includes asthma, which Richard has been diagnosed with since childhood, gout, hypertension, as mentioned as one of his risk factors for cardiovascular disease. As stated, he is a current smoker, and he has also previously had a cholecystectomy performed. Regarding medications not mentioned so far, Richard also takes allopurinol 100 milligrams daily for his gout. He has been prescribed a Symbicort 206 Turbuhaler for his asthma, but he reports he has not taken this. And finally, Richard is also taking omeprazole modified release 20 milligrams per day. I'm not actually clear the indication for this. Richard didn't feel like he gets significant reflux symptoms. Further details around his medications include the fact that he has no known drug allergies. Regarding his adherence to his medication regime, he reports he will, up to about once per week, may miss some of his medications because he is busy or distracted. He does not have any blister packs at this stage. He does not take any over-the-counter medicines or supplements, and regarding vaccination and preventative health, Richard is up to date with all the usual vaccines, except he has not had this year's flu vaccine yet. To briefly touch on some family history that Richard has, which plays into his other medical conditions, Richard's father and both of his siblings have type 2 diabetes, and Richard's father actually died of a myocardial infarction when he was 60 years old. Richard also has a family history in his mother of breast cancer. I'd like to move now to discuss Richard's social history. So Richard lives with his wife Margaret in a 2-storey house that they are renting. He is usually functionally independent with his activities of daily living, although he has been less able to help with more household maintenance tasks such as lawn mowing since his back injury and the subsequent ongoing pain. Regarding employment, Richard has been working as a truck driver for more than 20 years and understandably is quite devastated that he's just failed his heavy licence recertification due to his diabetic retinopathy. As I'll discuss later in my issues, this does place some significant financial concerns on Richard and Margaret due to the loss of his employment and the potential difficulty he faces with getting new employment. Regarding alcohol and other drugs, so as mentioned, Richard is a current smoker. He has managed to wean this down to just 5 cigarettes per day, but has about a 25-pack year history. He has made some previous quit attempts, but reports these never lasted very long. He actually drinks minimal alcohol at this stage, only on special events a few times per year, and he does report intermittent cannabis use to help manage his back pain. I did take this opportunity to briefly discuss Richard's mood with him in terms of how these medical conditions affect him, and the way he described it was that you've just got to keep moving forward, and he tries not to think about the effect of his medical conditions on his life going forward. We did briefly discuss the effect of Richard's medical conditions on his sexual function, and he did report that he has had some erectile dysfunction in relation to his type 2 diabetes, but he unfortunately didn't want to discuss that any further. Regarding Richard's relationships with the doctors and health practitioners he works with, he does describe having a reasonable relationship with his GP, but he doesn't see them on a regular basis, only generally as either issues come up or if they recall him in, such as for cardiovascular screening. He has not had any, as mentioned, he does not have any particular relationships with any hospital services or secondary care. Finally, discussing Richard's kind of advanced care planning and future planning, he does not have a will in place. He has never heard of enduring power of attorney, and similarly, he has never heard of advanced care planning. Regarding my examination findings today, I will keep these abbreviated for the purpose of the presentation. His heart rate was 76, and his blood pressure, as mentioned, was 148 on 96. He appeared clinically well today and was warm and well perfused with a regular radial pulse. His heart sounds were dual with no added sounds or murmurs. His chest was clear to the bases, and his abdomen was soft and non-tender to examine today. Fundoscopy was quite difficult today through undilated pupils. Regarding neurological examination, Richard's upper limbs were unremarkable for tone, power, reflexes, coordination, and sensation today. Regarding his lower limbs, these were similarly unremarkable for tone, power, reflexes, and coordination, but I note that Richard had reduced sensation to pinprick in the soles of both feet. His cranial nerves on brief screening were normal. Just to add a further lower limb examination I performed, his posterior tibial and dorsalis pedis pulses were palpable both bilaterally, and his feet were warm and well perfused. There were no obvious diabetic foot ulcers present on my review today. To summarise my time with Richard today, Richard has had a significant change in his financial security directly due to the complications of his type 2 diabetes. The experience of ongoing symptoms from his back injury are causing functional limitation for him, which is his biggest concern while trying to seek new employment. There are a number of issues I've identified for Richard today. The first issue is that of his diabetic control and the optimization of this. The second issue I've identified, as mentioned as Richard's biggest concern, is his current financial insecurity and the loss of his job in recent weeks. The third issue I would like to discuss is managing his high cardiovascular risk. The fourth issue is that of some further investigation and then management of his lower back pain. And the fifth issue I have identified is his current smoking.
Thanks, Dr. Farmery, appreciate that. Would you like to begin by discussing his diabetic control and how you would manage that?
Thank you very much. So regarding Richard's diabetic control, admittedly I think some more information would be useful in terms of making a plan for this. In particular, it would be useful to know his most recent HbA1c level, as well as observing the trend for those over, say, the last 12 months or so. Similarly, although Richard does not test his blood sugars, best management of diabetes includes regular checking of blood sugars to know if there is a trend and if medications or interventions could target a particular pattern or particular times of the day. Having said that, the way I would approach Richard's diabetic management at this stage, it would need to come from kind of multiple approaches. Firstly would be the non-pharmacological approach. As mentioned, Richard doesn't believe he's ever had any particular diet advice regarding management of his diabetes. So I think at this point, given the significant complications he has had, I would suggest referral to a dietitian for kind of the best possible advice for Richard and to help try and work that into his and Margaret's lifestyle. Similarly, advice for management with sustainable and regular exercise would be really beneficial as well, both for his cardiovascular risk as a whole, but also for his type 2 diabetes management. And I wonder about something like a green prescription or engaging with kind of local community programs to help with that could be very helpful. Regarding pharmacological management of Richard's diabetes, I think he would benefit strongly from some education around his dulaglutide and the auto-injection of that, as I think that would be a very beneficial treatment for him, given his cardiovascular disease as well. I would consider, depending on his blood sugar levels and HbA1c, that if his diabetic control has been so significant that he is having these complications, he may benefit from insulin to get the tightest possible control. But I acknowledge, given the difficulty Richard has faced with the use of dulaglutide, that this would probably need some extra education and support for him to do that himself. The final elements of management I would like to put in place for Richard would include engaging other services in his care, as I think this needs to be a multidisciplinary approach. Firstly, I think Richard would really benefit from engagement with a specialist nurse in diabetes. This could either be through his GP practice if they have one, or through hospital services. I do think, given the number of complications he has had, I would recommend that Richard is referred to the hospital secondary care diabetes clinic, just to really ensure his care is being optimised. And the last thing I would do was that I believe, given the signs clinically on my assessment today of diabetic neuropathy, I think Richard would benefit from regular review by podiatry services as well.
Okay.
To wrap all of that up, I would also like to liaise with his general practitioner to let them know all of sort of my assessment today and also the recommendations that I'm making.
Okay. Are you concerned at all that he's having hypos? Does he give any description of that?
Yeah, there's no particular clinical objective evidence for Richard having hypos, given he unfortunately doesn't know where his glucose meter is. He didn't describe any in particular, and I suspect, if anything, he did describe some kind of general symptoms at times of fatigue, although I acknowledge this is hard to tease out with his multiple medical complaints. No particular complaints of symptoms consistent with hypoglycemia, such as sweating or nausea.
He's not on insulin. Is he on any medications that could cause the hypos?
Yeah, so the gliclazide he is taking, the sulfonylurea, could potentially lead to, while he's only on it once a day, could potentially lead to hypoglycemia.
Okay. In the interest of time, the final thing I'd really like you to discuss is your differential diagnosis and management plan, including any investigations that you might have for the back pain that you elicited on history.
Thank you. So regarding Richard's back pain, as mentioned, he's previously had a plain film x-ray performed, and his understanding is this showed wear and tear. My presumption is that may represent evidence of degenerative spinal disease, possibly including osteoarthritis. But I think, given the presence for Richard of additional symptoms such as electric shock neuropathic sensations down both legs, and given the persistence of this pain over the last 3 years, I do feel that there's a role for further investigation, as I think there is a broader differential diagnosis for the cause of his lower back pain. It is possible that his lower back pain is simply musculoskeletal in nature or may reflect osteoarthritis, but I think I would want to consider other differential diagnoses such as an inflammatory cause for back pain, and I think a benefit of further imaging would be helpful to rule out something such as malignancy, whether it's a bony metastasis or deposit or impinging on the spinal cord.
Okay. Do you think he may have radicular pain, or are you not certain?
I think I, unfortunately, from time constraints, didn't have the chance to take a detailed history about that, those electric shocks he described, but I do wonder if those may represent a sort of sciatica type pain, a radicular pain, down his legs.
Let's say your MRI shows some degenerative changes, some disc bulges, but no spinal cord compression, no nerve root compression. How would you manage him?
So I think, much like his diabetes, I think this would best be managed for a couple of different approaches. I think something really important to acknowledge for Richard is that this back pain is having a significant functional impact on him, to the point that it may affect his ability to sustain further employment. So as such, I think it would be very reasonable to kind of come at this full on, so to speak. One of those elements may be to actually discuss with our orthopaedic colleagues and to ask for their input as to the role, while, as you mentioned in this hypothetical, if there was no nerve impingement or such, but I would want them to be involved and to ensure that someone from their service has reviewed the imaging to consider the role for operative management. Regarding non-operative management, there are a few ways we could approach this. Often physiotherapy would have a significant role in this situation, regarding kind of exercises and ergonomics and other considerations for his lower back pain. Given Richard previously didn't really want to engage with physiotherapy after his first session, I think that would benefit from some more counselling about the role of physiotherapy in this situation and what they might offer. Further, I would think there is a role for kind of optimising his pharmacological management if it does end up being just musculoskeletal back pain. I think there would be a benefit in considering the medications he's on, and potentially with discussion with a pain team, looking to kind of follow things like the Oxford Pain Ladder and starting with regular simple analgesia and potentially working up from there in a more systematic way.
Okay. Would you use non-steroidals in this gentleman?
So Richard has been taking non-steroidals already. To be honest, I have some reservations about Richard using non-steroidal medications. In particular, this is around his significant cardiovascular risk and the potential for peripheral vascular disease. He also mentions he may have some renal impairment, but I'm not entirely sure of whether there is chronic kidney disease present. However, given all of those together, I would be very cautious using non-steroidal anti-inflammatories for Richard. I would not necessarily write them off completely, as currently he is quite debilitated by this, and I would want to take this in consideration with maybe some more blood test results if I was able to review those, and perhaps a slightly more detailed review of his background, such as his previous renal function.
Okay. Any other non-pharmacological approaches? You've mentioned physiotherapy, obviously mobilising, and you've got your pharmacological management in terms of your pain ladder. Any other, just looking at him, anything else he would benefit from there?
I suppose something, I've mentioned this in regards to, for example, his diabetic control and his management of cardiovascular risk. But Richard, it seems, has never particularly engaged with any community exercise programs, and as mentioned, I think he would benefit strongly from input from dietetic services. Kind of on the whole, with both of those, ultimately is management of his weight. So I wasn't able to measure his weight or his body mass index today, but my clinical impression is that Richard is obese, and I know that one of the things that can improve management of back pain includes weight loss.
Indeed. Okay. Well, that is time up for us.
Thank you very much.
Thank you, Dr. Farmery. Appreciate it.